where we'll be trying to integrate the recent ADA topics into the Indian scenario. And what I'm going to talk about for the next 15 minutes would be about real world hypoglycemia, setting the context with an Indian setting. Over the last 20-25 years, we've actually seen that the geriatric population of the country is going up, and it is common knowledge to most of us that the diabetic population in India has been going up. We are now not only the world's most populous country, but for all practical purposes, we are also having the largest population of diabetes in the world. And the number of elderly people with diabetes in India is also increasing over a period of time. We don't have large-scale data about what actually constitutes the prevalence of diabetes. In fact, some studies, there was a Northeastern study which actually put the prevalence of people with diabetes at around more than 65 years at around 7.5%. Then there were some studies which actually very small studies which were done in isolated centers which put the number of people with diabetes over 75 years. The really elderly population at around 5%. Between 2018 to 20, we had a very large India-wide study which involved 72,000 respondents who visited various clinics. This was done both in an Indian setting, in a rural setting, as well as in an urban setting. And not surprisingly, they actually found out that the prevalence of diabetes in people who were older than 60 years of age was more than 60%, was more than 26% in over the age of 60 in urban setting, whereas it was around 10% in people who were in the rural setting. And this prevalence was maximal in the southern states, union territories, Punjab and Delhi, high in the northeastern countries, northeastern states, and slightly lower in central India. Thus underlining that fact that hypoglycemia is very common in the Indian population. And as far as the treatment pattern for hypoglycemia is concerned, even today, because of the low cost, insulin and sulfonylureas remain the most commonly used medications for the management of diabetes. And this has become a huge cause of concern. Almost all of us who are involved in our day-to-day clinical practice do know that the first drug which is prescribed for a lot of people because of cost factors after metformin remains a sulfonylurea. Now that DPP-4 inhibitors and SGLT2 inhibitors have come off patent, we have slightly increased the use of these molecules, but again, tolerability is an issue. Appropriateness of this molecule is an issue, especially in postmenopausal women. And because of very high blood glucose levels initially at the time of first contact with the doctor, we tend to use more of sulfonylureas. And once people, and especially at the general practitioner level or at the physician level, use of premix insulin or use of combination therapy with sulfonylureas and metformin remains the commonest prescription even today. And sometimes this can extend to very high and very irrational doses of sulfonylureas, which is what constitutes a major risk in our general population. We don't have corresponding Indian data, but if you actually look at US data, they had a study called INFORM, where they recruited a lot of elderly people who were at risk of diabetes and who were predominantly either on sulfonylurea or insulin. And when they actually took down the data from these people, they found out that people who were on these two particular molecules tended to have a much greater risk of hypoglycemia. And this risk was more in people who were using the older sulfonylureas as opposed to the newer sulfonylureas like glucometers. And also people who were on basal insulins and also the second generation insulins and analogs tended to have almost 50% lesser hypoglycemia than people who were on the older generation analogs. To be very precise, people who were on the second generation of insulin like glargine as opposed to people who were on NPH had 19% lesser risk of overall hypoglycemia and 43% lesser risk of nocturnal hypoglycemia. And it is this nocturnal hypoglycemia which actually contributes to cardiovascular events and mortality in this particular population. And the Golden study and the Inform study actually said that we should be focusing more on piping down our use of sulfonylureas and insulin in elderly population. And at the same time, even if we are using these molecules in this population, we should be on the alert for hypoglycemia and try to use the newer molecules wherever cost is not a factor. Coming briefly, many people do not exactly have a clarity what constitutes hypoglycemia. We have had many definitions for hypoglycemia. Many of the pharma interventions have actually muddied our understanding of hypoglycemia. To give you a brief perspective of this, The minute your blood glucose level goes below 80 milligrams per deciliter, the first pathway in this is shut down, which is the secretion of insulin. Once your blood glucose level comes below 70 milligrams per deciliter, this is what constitutes true hypoglycemia. And that is where your counter-regulatory mechanisms step in. First, your glucagon is increased, then your adrenaline is increased, then subsequently cortisol is increased. But in a lot of people with type 1 diabetes, as well as in elderly people, insulin secretion is not always shut down, especially in people who are already on exogenous insulin or sulfonylureas, which are not within your control. You do not have glucagon secretion is shut off. A lot of people will not have counter-regulatory responses, and hypoglycemia unawareness becomes a major problem. Many people, once they are accustomed to long-term hypoglycemia, start developing less and less neuroglycemic symptoms, and this is what actually contributes to their unawareness and lack of understanding of what the fact that they are having a hypoglycemic episode. So with each hypoglycemic episode, the tolerance to hypoglycemia goes up, and they might not even report symptoms even when their blood glucose levels fall below 54 milligrams per deciliter or 3 millimoles per dl, which is what constitutes what is known as a severe hypoglycemia. In addition to that, what many physicians are not aware is what is known as a relative hypoglycemia. For somebody who has a blood glucose level of 300 milligrams per deciliter, starting them on a high dose of insulin or using a large dose of sulfonylurea can rapidly bring down their blood glucose levels to around 120 milligrams per deciliter in a day or two. This might seem normal to us, but for the human body, it is an absolute drop of almost 180 milligrams per deciliter in a day or two, which the body construes as hypoglycemia. And the body can very well present with all the symptoms of a hypoglycemia, can also present with all the consequences of a hypoglycemia, including cardiovascular events. And this is the reason why we don't need to rush into managing diabetes, be it to bring down the blood glucose levels or to impress the patient. We can take as much time as we want. The usual median time we give the patient for controlling hypoglycemia is 3 months. And wherever possible, we need to try to use agents which do not cause significant hypoglycemia. And this has been again underlined by a lot of trials. Whatever the trial might be it VADT, be it ACCORD, be it ADVANCE, in almost all these trials, wherever intensive hypoglycemia was used, the long-term outcomes were definitely better, but at the same time, this came at a cost. The relative risk of hypoglycemia definitely went up. And as was seen in ACCORD, even the all-cause mortality went up once these patients were started on more intensive regimens. In fact, the number of hypoglycemic episodes was almost 4 times higher in the control group, in the intensive care group, as opposed to the control group. 1.06 episodes of hypoglycemia per treatment period versus 0.29 episodes of hypoglycemia in the control group. And the risk of unrecognized hypoglycemia was also double in the people who were in the intensive group as opposed to the control group. And it was after this that people started focusing more on less stringent control in people who had diabetes and who were in the elderly age group to prevent cardiovascular mortality. In fact, if you look at the risk of hospitalization in elderly people with diabetes, more often than not, in any person who is hospitalized because of an adverse event with a diabetic agent, it will almost always be a hypoglycemic episode. Very rarely do you have falls or hyponatremia, which are commonly seen with SGLT2 inhibitors, or for that matter, severe gastritis. For all practical purpose, an elderly patient getting admitted for an adverse event with a diabetic agent implies hypoglycemia and nothing else. And this can add to the morbidity of the patient, can add to the mortality of the patient, and can also add to the subsequent cost of the patient. And most of these adverse events are because of 3 groups of drugs: sulfonylurea, insulin, and the glinides. And more often than not, a lot of major hypoglycemic events in patients tend to get underreported. What we are seeing as far as hypoglycemia is concerned is only the tip of the iceberg. More often than not, patients do not report their hypoglycemic events to us for a lot of reasons. Many a time, like I've already said, they have had chronic hypoglycemia. They are unaware of the fact that they have a hypoglycemia. They do not correlate this with hypoglycemia. As you grow older, you tend to have very non-specific symptoms as far as hypoglycemia are concerned. Many patients can just present with simple dizziness, can present with sweating. These can be because of a multitude of reasons and not always attributed to hypoglycemia. So they think it's because of their diabetes, because of their age, or because of their cardiac medication. Many of them lack the knowledge that hypoglycemia can cause these kind of symptoms, and it is up to us to educate the patient. Many a time in our busy practice, we do not have time to educate our patient. It is always a very sensible measure to give the patient a handout, which tells them what exactly constitute the symptoms of hypoglycemia and what are the warning signs and what you should do if you have a hypoglycemia. Patients are, some of the older people are very apathetic towards hypoglycemia. It's become a part of their daily schedule for them, and they have become indifferent. In fact, even older people who drive do not commonly report hypoglycemia because they're afraid that their family members can bar them from driving. Loss of independence also becomes one of the major factors why people do not report hypoglycemia. These are all these reasons, both patient related as well as doctor related, which contribute to the risk of unreporting and underreporting of hypoglycemia. And if not recognized in time, this can lead to major adverse consequences for the patient. And it is an axiomatic fact that if you have had one hypoglycemic event, you are much more likely to have a second hypoglycemic event. And that is the reason why I always tell my patients to have a glucometer with them, carry the glucometer along with them wherever they go, and anytime they develop a hypoglycemia, immediately record their blood glucose levels because they check their, before they take in remedial measures, because we have to have an idea of what is happening with their patient. As far as the single most important reason for hypoglycemia is concerned, it remains overtreatment. If you look at a bulk of treatment for the elderly population, you will see, not only see that they are being put on insulin and sulfonylurea, more often than not, you will find out that majority of them are being treated with 4 mg, 6 mg, 8 mg of even relatively safer drugs like sulfonylureas. So you have to understand that there is a law of diminishing returns operates when you are treating people with molecules like with sulfonylureas. The more you increase the dose, the less is the amount of return. I generally try not to go beyond 2 mg of sulfonylurea in a day. You can go up to 4 mg, but rationally in the elderly people, it's good clinical practice to either stick to 0.5 mg doses or 1 mg doses, or at best 2 mg. Even insulin doses have to be rational. People tend to forget what is known as the Somoggy phenomenon. An elderly person waking up with a headache and a very high blood glucose level in the morning does not always need an increase in his insulin level. What is required here is a continuous glucose monitoring or a measurement of the early morning blood glucose level to see whether he's had a hypoglycemia at around 3 to 4 a.m. in the morning, after which a hyperglycemia supervenes. This person will not require an increase in the blood glucose levels. He actually requires a decrease in the blood glucose levels. And interpretation of all this data will require a continuous glucose monitoring, not monitoring your blood glucose levels once every 2 months when the patient comes to the OP. And it is for this reason that we always have to educate a patient to keep checking his blood glucose levels with a glucometer. And it is not always fasting and post-breakfast glucose levels. You have 24 hours in a day. They also have to do a before lunch, before dinner, bedtime, once in a while early morning levels, or use a continuous glucose monitoring, though many of the current CGMS probes in the market are quite inaccurate when it comes to hypoglycemia. And this is where, coming to the last part of the talk and looking at the bigger picture, we need system level interventions. Whatever I have told you now are something which is done at the individual level care. But what we have now is what is known as a system level intervention. And the need for system level intervention has become very acute in the US of late because of insurance pressures and increasing corporatization, which has already happened in India, is now happening in the US. Doctors are unable to give more time to the patients. They are not able to focus on the relevant aspects of care for the patient. The second part is the insurance system in the US actually rewards patients who have lesser HbA1cs. This has actually resulted in more and more targeted therapies towards lowering the HbA1c with very less regard to safety. So while rewarding patients for good clinical practices and good health practices needs to be encouraged, there has to be a limit to this. And an HbA1c of 7 should not always be the target. In fact, if you look at the recent American Geriatric Association guidelines, and if you look at their Beers criteria, they have come down to some extent on SGLT2 inhibitors. They have added a caution to SGLT2 inhibitors because of risk of euglycemic ketoacidosis. Caution about insulin and sulfonylureas has always been a part of the picture because of risk of hypoglycemia. And they have actually focused more on keeping the HbA1c cutoffs at around 7.5 in the elderly population, especially people with a life expectancy of not more than 10 to 15 years, who have cognitive dysfunction, who are bedridden, or who have diabetic comorbidities. In all these patients, it makes sense to have slightly lesser stringent glycemic target so that we don't overtreat the patient. At the same time, we don't relax it so much that they end up with diabetic microvascular complications. And of course, the most important part, and which is not always in our hands, is the cost of therapy. The single most important reason why we use sulfonylureas and insulin in the management of diabetes is because they are the cheapest medicines. They've been around for a very long time. If you look at recombinant insulins, they cost you very low. 200 rupees per vial is what would be the lowest cost for recombinant insulin. Sulfonylureas are available for as low as 1 or 2 rupees in a day. And this essentially leads to a tendency where we tend to overtreat people with this molecule rather than going on to the slightly more expensive molecules. But now that India has reached a stage where rightly or wrongly, we have taken the patent of a lot of medicines, we have forced patents of a lot of medicines. It has made more expensive medicines affordable to our patients, and it is time we started taking advantage of this particular facilities which have been provided to us so that we treat patients with more effective medications. I don't say that we should stop the use of sulfonylureas, but we should limit and rationalize the use of sulfonylureas. Wherever possible, try to use a basal insulin rather than using a premix insulin, or convince the patient, talk to the patient and split your insulin into multiple daily injection regimen rather than using two very large doses of insulin, split it into 4 smaller, more rational doses of insulin in a day. And this is where US has actually come up with what is known as the Choose Wisely Hypoglycemia Prevention Initiative. This has been started as a pilot project in a few hospitals where they actually pick up the patients who are visiting their OP who are at risk of hypoglycemia. The next time the patient comes to the OP, an alert is generated in the system. A questionnaire, a very small questionnaire is given to the patients about the risk of hypoglycemia. The responses are recorded, and if it is understood that the patient is having a hypoglycemia or has had an hypoglycemic episode and has not reported it, then an immediate decision is taken to dial down on the treatment. This is recorded in the EMR, and this template is developed further so that it can be applied to further people. This has already been completed and is now about to take off in a big way in the national setup. And I think this kind of initiative also needs to be taken up in India, and people like Sanjay Badada sir, who are in the vanguard of healthcare in the government sector, should need to do more of this, should be the people who should be taking up the onus of taking up these kind of initiatives in India, because overtreatment is as much as a problem in India as it is in the US. To conclude, the only thing I would say about prevention of hypoglycemia in the Indian population is, one, from a practice setup, what we as doctors can do. We need to increase patient engagement. We need to specifically ask patient whether they have had a hypoglycemic episode. Ask them whether for the specific symptoms of hypoglycemia. Tell them what they have to do. Educate them properly about insulin injection techniques and proper use of insulin. Slightly dial down on the doses of sulfonylurea and hypoglycemia, and educate them. The easiest way of doing it is giving them a paper pamphlet or a paper sheet about the risks of hypoglycemia, symptoms of hypoglycemia, and what to do if you have a hypoglycemia. Most of our patients actually tell us, I had a hypoglycemia and I took a chocolate and I felt better. This is not how you deal with hypoglycemia. You have to take 15 grams of glucose, recheck your blood glucose after 20 minutes. If it is still low, you have to increase your, you have to again take a second dose of glucose or sugar. This is the ideal method, and we have to make sure that every patient who visits our clinic and who's at risk of hypoglycemia is aware of this practice. Wherever possible, we need to ramp up diabetic education wherever financial matters permit. Make some YouTube videos regarding this, give them some pamphlets, or even put them in touch with resources or patient groups which can educate them better. Or just give them access to some websites like the ADA or the Endocrine Society, which has made up a lot of recent pamphlets about hypoglycemia and risks of diabetes so that they can read for themselves. But the biggest change does have to come from the policy department. One, the pricing of other molecules need to be brought on par with sulfonylureas and insulin so that these molecules do not automatically become the first choice, even in elderly patients. Many of the elderly patients are financially constrained, and by default, we have to use them we have to put them on insulin or sulfonylureas. Even a lot of times, even people who are living alone, who are very poorly controlled, need to be put on insulin because of these cost factors or poor glycemic control factors. And this is where policy changes do come in. And the other place where we can actually use this is technology. Use of better and more reliable glucometers. We now have cheaper glucometers, but as to how reliable they are is still a matter of debate. What we need to do at the policy level is make cheaper glucometers available to the patients, and most important, make sure that the glucometer strips which are available to the patients are reasonably cheap. Patients should be educated about easily disposing them, and the fears patients have about checking with glucometers need to be allayed. And wherever possible, continuous glucose monitoring should be utilized in a rational, effective, and an economical manner. And we always have to educate our patients that whenever you get a hypoglycemia, which is recorded on a CGMS, please corroborate it with a glucometer level, because CGMS is not always reliable in people with CKD who are at huge target risk for hypoglycemia, as well as in people with hypoglycemia where CGMS might not always be the most accurate method of recording a hypoglycemia. So if you only initiate changes at the patient level, at the physician level, as well as the government or the national policy decision-making level, are we going to make a dent in this huge risk of hypoglycemia, which is a clear and present danger even today in the management of diabetes? Thank you, and over to the chairperson, sir.